She's the pushy broad from the Bronx, New York. Follow her voice, a straight dog is nice. She's a pushy broad from the Bronx, oh yeah. Don't be surprised if you wanna listen twice. Make decisions, find the right choice. Know yourself better, find your own voice. It's okay if you need help today, cause everybody needs a little push. From the pushy broad from the Bronx, New York.
Welcome, Transformation Talk Network listeners. My name is Ellen Stewart, and I am the pushy broad from the Bronx. Welcome to my show, Recovery Recharged, where we share advice and support from experts in addiction and recovery. I have an amazing show here for you today. First of all, an old friend of mine has come to the studio today to talk with me about a topic that everybody wants to know something about. This gentleman's name is Nelson Hadler, and he is certainly an expert in the field of addiction and recovery. He's a licensed clinical social worker, a licensed certified alcohol and drug counselor who has over 30 years experience in the addictions and mental health field. He specializes in the topic that we're going to talk about today, and that is the dual diagnosis challenge, which means that he specializes in what we call co-occurring disorders, general mental health issues, and, of course, addiction. So it's my pleasure. The pushy broad from the Bronx is certainly thrilled to welcome again my dear friend, Nelson Hadler. How are you this morning, Nelson?
Very good. Thanks, Ellen. Great to be here.
Thank you so much. So for those of us that have heard the words dual diagnosis and co-occurring and all of that stuff, can you give us an idea in layman's terms what it means by co-occurring and dual diagnosis? Is that the same terminology for us that don't know?
Well, the terminology's evolved over the years, way back in time in the AA world, there were double trouble meetings for people with co-occurring disorders, mental health disorder. And, then I think in the public domain, it's MICA, mentally ill, chemically addicted. That was kind of old and stuffy. And then it became dual diagnosis, but that evolved into co-occurring because dual limited it to two. And we realized, so you could have a bipolar disorder, an alcohol use disorder, and be homeless. So you'd have three problems. So it was multiple problems.
I see. Okay. So is it common, very common, do you see in practice, and I know I see the same thing, how often do mental health disorders influence addiction? Do you see lots of people that are addicts with co-occurring disorders?
Yeah, most are. I mean, the word these days is it's really, really almost never that you're going to identify someone with just a substance use disorder that doesn't have something else going.
I see.
Really evolved to that. Whether it's something mild, like, the person stops drinking, maybe he didn't go to detox, but he experiences some anxiety for a few days, and then it doesn't go away. And we go, it's been a week. You're still anxious. Maybe this is an anxiety disorder. Maybe that it's something to do with your substance use. So
I understand.
a lot of times a lot of times it presents, someone may come in and present with a mental health disorder. And we don't really identify that the substance use is a huge problem. And then other times people come in with a substance use disorder, but it's totally masking what's underneath. So a lot of times it takes getting sober early on in treatment to start to identify, maybe there's something else going on.
Great. Thanks very much. So based on your practice, I know you also work heavily in addiction as well. Give me some of the common types of co-occurring disorders and explain to us exactly what the symptoms look like so those of us out there can identify them.
Wow. Well, there's a lot of them. I think the hot topic today is trauma and depression. And more and more we're learning as people are doing intakes into treatment facilities. We're learning we really need to screen for all of that. Um, but you really have to do a full biopsychosocial and mental health evaluation on anyone coming into practice or a treatment facility. Um, it can be anything from psychotic disorders to traumas to a history of abuse. A lot of times we'll see a person um, come to detox, and a few days in, all of a sudden they're in a manic episode, and oh, they weren't taking their meds for their bipolar disorder, and the other drugs and things they were taking were kind of masking it. So it's kind of broad. You really have to look for it all. Ask, do you have a history of psychosis? What does that mean? Have you seen things, smelled things, heard things? You know, um, anybody ever thought you had a bipolar disorder? Um, you know, did you ever, have you ever not slept for a day or two, yet not been tired and felt energized? You have
Right.
to, I mean, you really have to be versed in diagnosing all the general mental health disorders, to know what to look for.
And the most important thing that I want everybody out there to realize is that the addiction may just be a symptom of a mental health or co-occurring disorder. That sometimes happens as well. Also, understanding, just as Nelson said, it's very difficult sometimes to diagnose the co-occurring disorder until that person has decided to get clean and sober. Because when they are in active addiction, there are lots of things that look like a mental health disorder that may not be. So, the only
Exactly.
way to really diagnose is to make sure that there is some sobriety. Okay, so let's move on.
Okay.
What are some of the initial steps in treating someone with both the addiction and co-occurring mental health disorder? When you sit down with someone and you're beginning the process, and you said you do a biopsychosocial, which for those of us out there means a very detailed assessment, a written assessment of history, family history, asking all kinds of background questions. What's the beginning? What do you look at first? Do you look at the addiction? Do you look at the co-occurring? How do you proceed?
It really depends on the individual and what their motivation is and the setting. I mean, if you run an inpatient rehabilitation facility for substance use disorders, you're going to tend to say, oh, I'm a hammer and everyone's a nail, because that's your lens. And you also have to kind of have a consistent philosophy. So when someone comes to an intensive outpatient program and they're diagnosed with, substance use disorder, um, what's the philosophy of that program? Does everyone have to go to AA? Um, so it all depends on the facility, the philosophy, and like I said, the setting. One of the things that's the great thing about not running a facility and just being in practice is you really get to individual. But even, to answer the question, in the facility, you want to keep an eye out for what's manifesting as the person gets over, you know.
I understand. Okay, so it's very important, and I find with my clients as well, it's very important to, as a treatment provider, as a recovery coach, or as an addiction therapist, to really listen to what the client is saying so that you know how to integrate treatment approaches. For instance, if you have diagnosed that the person is ADHD, attention deficit
Mm-hmm.
hyperactivity disorder, then obviously you're talking to them differently in your approach in order to get things done, correct? I mean,
Yes.
you have to approach people differently. So explain a little bit about what that's about, because one of the common things we see in young adults, especially, is now the ADD or ADHD. So talk to us a little bit about that, ADD, ADHD, and addiction.
Well, as far as in treatment, what's evolved over, especially the last 10 years, is really taking your psychoed curriculum and integrating um, modalities that use different learning styles, so that your ADHD person might learn better in a certain learning style. Maybe they don't read very well or sit in a lecture very well, but if you do something interactive or you show a movie so you kind of have to spread that out. With ADHD, you need to take a look into, what's the goal of the substance use? And a lot of times it really is to combat the ADHD. That's the primary thing. I remember I had a kid, he was insisting how pot treated his attention deficit disorder. And the parents were frustrated, and he was in what we had a multiple family group. So the family's like in the middle of the room. All the staff and the other families are there. That's a whole concept to explain. But anyway, I'll never forget this young man looking at his mother and father, very frustrated, and saying, "Mom, Dad, you don't understand. My head is like a circus. There's a trapeze guy over there, a lion tamer over here, a bearded lady over there, elephants over there, and I can't focus on any one thing. I smoke a joint and I can watch an elephant." And I'll never forget that was like in, burned into my brain. I'm like, that's exactly what it does.
That's
So it is it is adaptive, meaning the person is trying to function appropriately, not just get blasted. You know. So if you don't replace that, what are we going to do for that? Then
I
you're
understand. Yeah. Then if you don't replace that, then the patient, the person, the kid is going to continuously do it because this is the way that he can calm down his brain. So we
right.
see this a lot, and this is one of the reasons why I wanted to bring this program specifically today to those of you out there, especially family, and I want to talk about family in a moment. But ADD, ADHD, one of the things that I hear all the time from clients as well is exactly what Nelson is talking about. Marijuana and the properties behind vaping, THC, whatever it is, smoking, is to slow the brain down from all of these thoughts that are coming at them a mile a minute. And there is a very good argument for continuing to indulge. So the therapeutic approach is to find ways to substitute the marijuana and still allow people to be medicated on ADD, ADHD, or find them tools to quiet the brain. Correct,
Exactly.
Nelson?
Yes, exactly. Unfortunately, the most effective ADHD medications are stimulants. They're methamphetamines, basically. So that's not the number one indicator. Although a lot of people in recovery might have been drinking or using other drugs for 20 years and never abused their Adderall. And they're not going to. And so we need to individualize. Okay, Bob seems to be able to use his Adderall and is not at risk of abusing. So that might work. But for other people that are at risk, tools don't work anywhere near as well as drugs, and you have to teach the person. It takes some patience. But there's a whole lot of protocols and tools, time management, thing called the Pomodoro method. You study how long, take a break. I mean, there's all sorts of tools we can use, but they take more work than. And a
Yes.
lot of times people are misdiagnosed with ADHD. It's one of my pet peeves. Um, and sometimes, I'm gonna be like, I don't think you're ADHD. I think you're really anxious and you're medicating the anxiety, you know. But yeah, I mean, I know people diagnose this, but I don't know. I mean, to me, one of the great diagnostic tools for ADHD is if the stimulant works. If the person takes Adderall and they report that they calm down and they can focus, they probably have ADHD. If the person takes Adderall and they say, "Yeah, it was great. I stayed awake so I could study, but I was really wired," you probably don't. So, I mean,
Well, that's a good thing to know, and that's a really good thing. And also, we know that there are ADD and ADHD medications like Vyvanse or Strattera
Yes,
that are non-opiate based, and there are many people in recovery that are on Vyvanse and
yes.
Strattera that do work very, very well. So I want you guys to understand out there that there are ADD meds that are not opiate based. So moving
Yeah.
on. Let's talk about the family. All right. So let's see, how critical is family involvement in the recovery process, especially with people for dual diagnosis? How often do you get in front of a family member?
Family involvement, I think research has proven, is the most effective way to provide treatment. And I'm a huge family involvement guy. When I had treatment centers, all my programs had very intensive family involvement, and even for, I forget the gentleman, the doctor's name, but even for mental illness, there was I think it was in the 60s or 70s, a doctor in one of the psych hospitals in New York City started to have visitation on Sunday. And this is for schizophrenia. And he would have visitation on Sunday. He'd come in and he'd do education. And this evolved into a multiple family group, the same style that was adopted in treatment centers for substance abuse and used, especially in adolescent programs for years later. But this was for the families and the individuals diagnosed with schizophrenia. And its focus was education, communication, and ending stigma. So it's very important. And as I said, the substance abuse world kind of took a lot from that doctor's multifamily group model and used it. To me, it's very important, and especially early on, to have family involvement. So you educate the parents or the spouses, and you teach them what's going to work and what's not going to work. You know,
That's a very important thing. I also, when I take on my clients with their permission, obviously, I try to have a session or two or three or four with the members of that person's family because they do need an education and in many ways learn how to better communicate with the person that you're seeing in treatment for sure, for
yes.
the learn about addiction, understanding that we have learned from years and years and years of study that it is a family disease. What do we mean by that theoretically? What do people have to know in the short form? What do we mean by it's a family disease, Nelson?
Well, number one, it runs in families. It's genetic, and oftentimes it's multi generational. And so when we get that individual in treatment, we're actually changing a generational trend. You know, and so now you have the parent. Let's say you get an adolescent in treatment with substance abuse issues. You get the parents in treatment, and maybe the mom has a substance use issue. Maybe that needs to be addressed. Maybe we really need to help dad identify. Gee, there's treatment for this.
And also, it helps the family communicate, and in addition to which, allows them to understand that they may be directly responsible for exacerbating certain things in the home.
Exactly.
And also understanding that it's not only the person suffering from the addiction or the dual diagnosis that has to do the work. The family has to do the work as well. You cannot bring that person back into the same environment and expect them to succeed if you're not going to help them out by doing so, right?
Oh, absolutely. That's why I'm a firm believer in involving the family and doing a lot of treatment.
Right.
Yeah.
Absolutely. On a regular basis. Okay. So, what have you seen? I mean, I know you're in private practice for how long now? 30 years, we said, 30 years in
Yeah.
private practice and
At
all
least
of those
part time.
things.
Yes.
Right. As and of course owning and operating intensive outpatient, treatment centers and working as a clinical director for several of them as well. In your experience, do you find that there are great long-term recovery prospects with someone that suffers addiction and dual diagnosis? Do you have more successes in terms of those individual recovery situations?
I'm sorry, I'm not clear on the question.
I mean, have you seen more successes in your career than failures in
Probably
terms of
not.
their
Not not in the rehab AA world. You know, the old thing. Um, if you go to a group in a treatment center, they say look to your left and look to your right. Because of you three folks, only one's going to make it. They tell you all these awful odds. You know, um, but I define success differently. Even my treatment programs when I ran my treatment center, they weren't harm reduction programs. We didn't say just smoke pot and that's okay. But in the sense that, okay, adolescent treatment, the adolescent meets criteria to come to an intensive outpatient program or go to rehab and then do that as aftercare. Um, the odds of an adolescent staying sober when they're mandated that type of treatment are very low. But you know what? They were in my IOP for 3 months and we got in the way or they're getting high. So they didn't get high for a couple months or they got high a lot less. And they were able to access emotions and hopefully sit in group and connect with people and have the experience of, you know, after a few weeks, it wasn't that bad. And we keep and my other staff that holds me up when I was, all this, like, they don't stay sober, they stay alive. We get in the way of them having those awful types of consequences. And um, maybe it's 4 or 5 treatment stays until the light bulb goes off and they go, oh, I really want to do this now. And those are the moments where that's a real success. When the person that you met when they were 14 years old and went through your intensive outpatient adolescent program twice and you sent to 3 rehabs, did some time in jail, came out, did a long-term treatment, and then call you up and they say, Nelson, I'm really ready to get sober now. Will you help me out? Like, I know I need to do this. Those are the golden moments. Sometimes it takes forever. So yeah, I've had to hang my hat on that. So
Okay,
we
okay.
do,
So
we do. Go ahead. So
it's okay. I always talk about the fact with my clients that as long as they're alive, there's hope. Okay.
yes,
If you are going to go down the deep end to no return, and if we're going to have to bury you, then of course there's no hope.
right.
However, an education, meaning some treatment, is always better than no treatment, whether it's an intensive outpatient program, a residential treatment
Yes,
center, a therapist, a recovery coach, someone that is beyond yourself that will get you the help you need. And sometimes for us, it's going into a 12-step meeting or talking to somebody, on the phone that does support. There are so many ways to get help. The danger is not doing any of those ways because
I
then you
agree.
have no chance whatsoever. So,
Mhm.
when you have someone that is somewhat successful, especially now in private practice, you're dealing with more adults. Do you find that they're making major lifestyle changes to really get ahead? Are those the clients that you're seeing? Do you think that they actually really transform their lives to stay sober?
Yes, yes.
Okay.
A lot of clients, they come into treatment or they find me after detox or after rehab, or you know, they're going to 12-step meeting currently. Like, yeah, a lot of people, it's the old school, oh, this isn't working. I need to do this another way. You know, a lot of times it's walking next to the person going like, I'll be with you with this, but I don't think that's a great idea I don't think just doing cocaine and not drinking is going to work, but let's see. And sometimes they have to jump through those hoops, but then they get to the point where it's like they get it. They truly surrender. I mean, Yeah,
I yeah, I understand. Look, I love what I
you know,
do.
you understand.
Well, listen, I love what I do because I like the fact that that clients really want to try. And maybe they're a little resistant in the beginning, but they do come back. And in the 15 years that I'm in private practice, they do the right thing. They come back and they let me know they're okay, or at least they come back and tell me that they're really trying and let's do it again.
Good.
And that's why I keep doing what I do, because thank goodness over the course of time of being 20 years in this industry, there are very, very few people that are no longer on this earth because of the work that I've done with them. So I
That's right.
really, really appreciate your coming here today. Thank
No
you so
problem.
much for opening up and telling us all about it. This is Ellen Stewart, the pushy broad from the Bronx, saying go to my website, pushybroadfromthebronx.com. Go for the free consultation. I'm right there. I'm here to help you. Thank you very much for listening, and we'll see you next time. This is Ellen Stewart, the pushy broad from the Bronx, saying thanks for listening, and remember, everybody needs a little push.
From the pushy broad from the Bronx, New York.